Hi everyone, I'm John Stubbs, and in my capacity as Chair of PRISM, I'd like to welcome you to our event recognising the 40th anniversary of the HIV/AIDS epidemic and World AIDS Day. In partnership with Heart and Impact, PRISM continues to drive our education agenda, and you have given us feedback that getting back to basics and education is something you value, and you're certainly going to get that again today. Our session features two of our executive committee members, Hanneke Schmitz as PRISM's new executive sponsor, and Senthil Kumar, whose passion for DEI is evident in his approach to risk and compliance for the firm. We're grateful for their leadership and support. We feature a panel facilitated by Anna Simmel, new to our organisation and already making an impact by demonstrating her active allyship by getting involved in our EBGR work. Anna will introduce Dr. Eric Eitang from Mount Sinai, who will offer a keynote, and then join our panel alongside Derek Frost, author and founder of AIDARC, and Emma France from Mothers to Mothers. Please get ready for a rich and, on occasions, a raw discussion about the realities of HIV/AIDS, past, present, and future. The discussion is educational. It touches on emotions of fear and renewed hope, of stigma and calls for renewed understanding, given all of our experiences of the COVID-19 pandemic. And as we close today, Senthil will touch on empathy, sometimes referred to as a soft skill, but more than ever an essential need of all of us. Before I hand over to Hanneke, I will shortly be recording a conversation with one of our panelists, Derek Frost, whose memoirs entitled Living and Loving in the Age of AIDS have recently been published, and we will release extracts of that conversation in 2022. I know, having read Derek's memoirs, that you can expect another honest discussion, which will go through his own journey from finding love to dealing with fear and finding hope, and then importantly, supporting others on their own journey towards hope. More on that in the new year. So Hanneke, welcome to PRISM and congratulations on your appointment as our executive sponsor. Over to you.
Thank you, Jono. I'm just so delighted to be working alongside you and the team as the executive sponsor of PRISM. I'm also delighted and thankful for our colleagues at Heart and Impact for their partnership and collaboration to make today happen. And finally, my thanks go to all of you for being here today in recognition of the 40th anniversary of World AIDS Day. It's worth noting that World AIDS Day was actually the first ever global health day, with the first being held in 1988. It is the longest running disease awareness initiative of its kind in the history of public health. Now, this effort actually really began to raise increased awareness of HIV and unite people across the globe in their fight against the disease. And it also today continues to serve as a time for us to recognize and support not only those living with HIV, but also to remember the more than 35 million people who lost their lives against the disease. But we've certainly come a long way in the 40 years since the beginning of the AIDS epidemic. Now, I do remember that time full well. In the early 80s, I was a teenager living in the Netherlands, and I very much recall when this illness was identified, both the fear that existed in the community, in particular the sort of the younger community, as well as the stigma that was associated with the disease. Now, 40 years on, improvements and advancements in HIV care and treatment have made dramatic strides in helping people with HIV live long, healthy, and fulfilled lives. And what I think is particularly critical is that we've made real progress in reducing some of the stigma and misinformation associated with AIDS. But this work is far from over. And as we will hear in the dialogue today, where we're going to be addressing the myth and misconceptions about HIV and AIDS. In conversations with various PRISM members and taking on my new executive sponsor role and reflecting upon our June Pride Month event, Transgender 101, I know that continued education remains paramount. One of our goals at PRISM is back to basics. And what this means is that we really have to learn and grow by asking questions and really to seek out to both diverse as well as experienced points of view. Because it is only when we're open to being lifelong learners and recommitting or indeed committing to educating ourselves that we can all do better, but also be better. And as we've witnessed throughout these nearly last 2 years of the COVID pandemic, education, awareness, and equitable access to quality information and care are just critical in combating disease, as well as the prejudices often surrounding it. Dr. Eiting, who I'm delighted is joining us today as our keynote speaker, will talk in more detail about the parallels between COVID and HIV, in addition to the impact COVID's had on HIV as a public health threat. It has taken a particularly devastating toll on the countries and populations that have been left behind in the global response to AIDS, such as South Africa. And this is why allyship, in my view, is so incredibly important. I believe that through active allyship, we can use our voices and platforms to advocate for others who don't have one. And we can shine a light on those who are left behind, excluded, or marginalized. And when we band together as allies, just as we're doing now in recognition of World AIDS Day, we have the power to effect real change. And that the power to affect and the power and ability to affect real change is what inspires me to get more involved in communities like PRISM. And this is also what fosters a truly inclusive workplace culture, where everyone can be themselves and feel a real sense of belonging. So thank you again for taking this time today to listen to different perspectives and experiences and to learn from one another as we reflect on the past 40 years. I'm hopeful that we will see more significant breakthroughs in the next 40 years that eradicate not only HIV, but can also prevent future pandemics. And now, without further ado, Anna, I'm turning the floor back over to you to introduce Dr. Eiting. Thank you.
Welcome to the PRISM World AIDS Day 40th anniversary event. Today, I am honored to be joined by 3 fascinating individuals to discuss the past, present, and future of HIV/AIDS. Our keynote speaker for today is Dr. Eric Eiting, the Vice Chair of Operations in the Department of Emergency Medicine at Mount Sinai, who has spent his career advocating for vulnerable patient populations. He will be joined on the panel by Derek Frost, the author of Living and Loving in the Age of AIDS, and founder of AIDS Arc, a charity which helps people living with HIV by providing antiretroviral drugs, related medical and social care. And also Emma France, the founder of the UK and European Office of Mothers to Mothers, an international non-profit organization dedicated to preventing mother-to-child transmission of HIV by providing education and support for pregnant women and new mothers. Thank you all so much for joining today. To begin today's panel, Dr. Eiting, I am passing over to you for your keynote.
Thank you. I'm very excited about the opportunity to talk about this now that we're looking at the 40th anniversary of HIV and AIDS. This is a topic that is very near and dear to me. As you can see, this is a little bit about me and my journey. How I came into the field of HIV and AIDS was actually in the early 2000s. I had joined an organization called AmeriCorps, and I was working as a volunteer doing HIV counseling and testing in Brooklyn. And having watched the impact of this disease in the 80s and 90s across the globe, I really felt a call to action, and I really saw an opportunity to be a part of this. This was happening at the time that we were starting to see a new face on the disease of HIV and AIDS. The first protease inhibitor came onto the scene in 1995. And so by the time I had started working as a volunteer, we were already seeing this start to transition from something that was oftentimes considered to be a death sentence into a much more manageable chronic disease, but still with its own challenges. This was a time when many people were taking 3 or 4 different medications to keep their HIV and AIDS disease condition at bay. Many of these were taken multiple times in the day. Some had to be refrigerated, some had to be kept at room temperature, some had to be taken with food, some had to be taken on an empty stomach. So the medication management piece was certainly challenging, but again, it really offered a new opportunity and I think started to transition the movement to a chronic, a manageable chronic disease. And so that was a very exciting time to be involved in this field. Over the years, I've done a series of advocacy activities, and I do think that HIV and AIDS, while very tragic, it also has given opportunity to shine a light on some of the disparities in some of the people who are more likely to be afflicted or infected with HIV and AIDS. And that's been really rewarding work. Just to give a little bit of an overview of some of the things that I'd like to cover today, we'll talk just a little bit about the journey of HIV and AIDS, where we've been, and really taking some time to talk about what's going on right now. I do think that it's worthwhile for us to bring up just the fact that we're also dealing with another pandemic right now, a global pandemic called COVID-19, which we're all well aware of. And I think that there are some similarities that we see between the two diseases and also some distinct differences. One of the most common themes that we see between both of them is the striking healthcare disparities that we see. And oftentimes, even across the globe, we're seeing that there are some people that are much more likely to be afflicted by this, much more likely to have issues with access to healthcare, much more likely to suffer more difficult and serious outcomes, including death. And so that I think is one theme that ties the two of these. And then I just wanted to talk about the hope, just talk about what's on the horizon, what's going on right now, and what we're looking at into the future. Just to remind people that while it's been 40 years, and I think that every single one of us wishes that this could be something that we're in the past and not the present, I do see light at the end of the tunnel, and I do see opportunities that should give us hope that we may be able to achieve some of the bold goals being established by organizations like the World Health Organization. Just to give a little overview, and then these are statistics coming from the WHO, the World Health Organization main site. One of the things that I thought was interesting in putting this lecture together is there was certainly a time in the not too distant past where it was so easy to find statistics on the WHO homepage. And I have to tell you, right now, with everything that's going on with COVID, with this other global pandemic, I actually had to go and search for some of these statistics. So it really tells you that this may not be in the same forefront that it was previously, but it doesn't change the fact that it is a disease that we continue to struggle with, and we continue to work towards a cure and towards managing this complicated chronic disease. So we still have 38 million people across the globe in 2020 who were living with HIV and AIDS. 67%, so 2/3 of those cases we're still seeing in Africa. So again, it really just highlights some of the healthcare disparities that we see here and some of the challenges that we have to face in overcoming. In 2020, 680,000 people died of HIV-related causes. So again, this is something that continues to impact us. There was a lot of overlap with COVID-19. And so that can certainly be contributing, but 680,000 people is certainly a striking number, 40 years into this, to see them die of HIV-related causes. 8% of those cases are happening in children under the age of 19. And we're going to hear some great things about a lot of the efforts to eliminate mother-to-child transmission. But with a number like 8%, we still continue to struggle in this arena. And so there are still opportunities for us to continue the work. And then 120,000 children died in 2020 due to HIV-related causes. So again, very, very striking numbers. I think that this makes this a disease that, while much better than it was, and while a more chronic disease that can be managed, it still continues to present a significant amount of morbidity and mortality across the globe, especially amongst children. In that journey, we have seen so much that's happened, whether that is happening in with respect to research, far more medications that are coming. We're doing all kinds of research in trying to understand the strategies that help us prevent the transmission of HIV and AIDS. So it gets much more complicated than just managing somebody's individual condition, but trying to take that public health perspective and really understand how you can try and bend the curve. There are all kinds of increased treatments. And so we're looking at several medications that are injectables. A lot of the medication regimens have been simplified to just 1 or 2 pills a day, which I think has had a significant amount of addition to the quality of life of people who are living with HIV and AIDS, not having to take these complex pill regimens with medications that they were required to take multiple times a day. The impact of education and awareness, I think, can't be underestimated. It's something that we have worked on for a very long time. I think that in the beginning, we saw that so many people were not given a face, not given a voice, and they oftentimes fell into the shadows. So I think it's so important for us to continue to focus on awareness. I think it's really important that we reduce the stigma. I'm going to talk a little bit about, in our hope message, about some of the strategies that we're using that help us have been successful in fighting the stigma, but making sure that that people don't suffer that same stigma that they did early on in the disease, I think is really important. And then, of course, again, as I mentioned already, there has been a significant impact that's disproportionately large on several disadvantaged communities, whether that's in certain countries, in the developing world, whether that's in developed countries and particular communities, whether that's within certain racial and ethnic groups, whether that's within the LGBTQ community. There are so many areas where we've seen and highlighted some of the disparities. And so it really just pushes us to double down on our commitment to address some of those underlying disparities. Now, one question that I get often is HIV an epidemic or is it a pandemic? And so I think it's worthwhile just for us to walk through some definitions. An epidemic being a disease affecting many persons at the same time and spreading from person to person in a locality where the disease is not permanently prevalent. So the WHO further specifies epidemic as occurring at the level of a region or community. And then a pandemic is an epidemic that is spread over a large area and prevalent throughout an entire country, continent, or the whole world. So when we look at the strict WHO definitions, they still define HIV and AIDS as a global epidemic. Now, I've definitely done some work in public health. I think it's a lot more impactful to use the word pandemic when describing this. I'm not, looking to start a fight with anyone from the World Health Organization, but I think that words really do matter, and calling it a pandemic just gives it the attention that it deserves. So that's really, the main difference. I know it's a little bit of semantics here, but to me, it's really important in sending the right message. When we look at some of the correlation between HIV and AIDS and COVID-19, right? So, I mean, we've got some striking similarities, right? In the beginning of the HIV and AIDS epidemic, governments were in denial. They were downplaying it. They were saying, this is not a real thing. There's nothing to worry about. There's nothing to see here, right? And we saw the same response in COVID-19 in the beginning, right? There was not a lot of transparency that was happening on a global level, which I think presented a lot of challenges in helping us get prepared for this. Over 40 years, we've seen 80 million cases of HIV and AIDS. We've seen COVID-19, 200 million cases in 2 years. So there's a stark difference. And I think that honestly is the main driver in the approach that we've seen to this. It's the opportunity for infection is much greater in COVID-19. So we have had to take a very different approach. Over the 40 years of HIV and AIDS, about half of those people, it's about 37 million people, have died. And that number of deaths, while it's over a much longer period of time, it is far greater than the impact that we've seen in the 4 million deaths of COVID-19. Again, these are opportunities for different strategies with both of them. And I think a really important piece that's not to be lost is that if you do not get treatments and you contract HIV and AIDS, there's a 95% chance that you will die. 95% of those people have died. Whereas so many people who get COVID-19 will recover, perhaps have some long-term sequelae, but in general, they will mount a full recovery, and oftentimes may even have very mild or asymptomatic infections. And then the last difference between the two, obviously, we've been able to stand up a vaccine for COVID-19 in a very short period of time. A lot of that is because the research that's been done on different coronaviruses has actually been in the background going on for a very long time, which has given us a lot of opportunity. But there still is no approved vaccine for HIV and AIDS. Although one of the reassuring things is now that we've been able to develop a tried and true mRNA vaccine. In fact, we have 2 different ones, and perhaps more in the pipeline. That technology may pose new opportunities for HIV and AIDS in terms of being able to develop a vaccine. So very, very different diseases, but a lot of very recurrent themes. And HIV and AIDS is viewed as a disease that impacts some, while COVID-19 is viewed as a disease that impacts all. But again, it's so important to remember that the striking disparities continue to exist, and that really forces us to hold our feet to the fire and challenge us to make sure that we continue to address these as we try and work on eliminating HIV and AIDS. So the last thing that I'll talk about just is, what's here now, what's giving us hope, and what's on the horizon. I think the first thing, and that really has been an absolute game changer, is PrEP, or pre-exposure prophylaxis. The idea of taking a daily medication to help minimize the risk of contracting HIV and AIDS. This really has been a very effective mechanism. One of the things that we continue to see, though, is that there are striking disparities in the availability and the willingness to take PrEP as a medication and use it as a prevention strategy. So while I think it's definitely changed the game, I think that there's more work that needs to be done in making sure that everyone has affordable access to what I think can be a life-saving, life-altering medication and help effectively prevent the spread of HIV and AIDS. The concept of the U equals U slogan, or undetectable equals untransmittable. And I think that this has been a really great opportunity, one, in reducing the stigma, and 2, making sure that we're taking advantage of every single opportunity from a public health standpoint to minimize the amount of spread. So giving that additional incentive for patients living with HIV and AIDS to get to that point where their viral load is undetectable, and then offering them the opportunity to advertise that with other people as a potential prevention strategy. I think that this has gone a very long way in reducing the stigma. And so that too is a campaign and a message that I think is giving us a lot of hope. And the last thing that I'll talk about very briefly is vaccines. I think that there's a lot of exciting movement, that even though we are 40 years into this, we continue to struggle with some of the challenges of HIV and AIDS. It is a tremendously complex, complicated virus that has amazing ways of mutating and protecting itself, hiding itself from our own immune systems, which has posed an insurmountable number of challenges. But as I said, I think that seeing what's happening with the mRNA vaccines, there I think is a newfound sense of hope that this may be an opportunity to see if perhaps we might be able to develop an effective vaccine and have that widely available. So there you have it. There's where we've been. I hope that you have the same sense of hope that I do. While it's important to acknowledge and mourn the people who've been lost, and to acknowledge the people who continue to be affected and infected with HIV and AIDS. I feel confident that this is something that we're going to continue to work on, and I pray for the day when we can look at HIV and AIDS as just something that was in the past that we figured out and we were able to move on to the next phase. So thank you for the opportunity to speak with you.
Thank you so much, Dr. Eric. That was fantastic. Thank you so much for sharing your knowledge and a little bit more on the message of hope, because I think that's incredibly important when it comes to things like HIV, AIDS, and pandemics, I'm going to go and say. So I think to begin the panel discussion, it's important to start from the beginning. So I think I'm going to pose a question to Derek first. As somebody who saw the beginning of HIV/AIDS, what was your first memory and recollection of hearing about HIV/AIDS, and how did that impact the community at the time?
I guess I first heard about it in the early 80s. You know, we spent a lot of time, we being Jay, my husband, and I, spent a lot of time in America in the 80s. We had a place that we used very regularly in Key West, Florida, which was a huge kind of gathering spot for gay people. It was a huge party place. And it was definitely there that we first heard about it. I mean, we started going there in 80, and the famous first article that was written about AIDS in the New York Times was written in July 81 that identified 41 homosexuals, etc. And that's when we first heard about it. So it was a long time back. And we kept going to America a great deal during that period of time, both on the West Coast, the East Coast, and you know, New York and Florida. And, you know, we started to pay a great deal of, you know, one couldn't but start to pay a lot of attention to what was happening there. So that's where I first encountered it firsthand, and it's where our friends started dying.
And what was the feeling around that time in the community? Was it one of fear or of the unknown, or very much looking at it from a perspective of, oh, it won't impact everybody? It was what was the consensus around it, I suppose?
Well, I mean, when you're young, you think you're indomitable. You know, you don't think you're going to die, and you're having, you know, I mean, AIDS struck at a most extraordinary time because, you know, homosexuality had become legal. I mean, in the UK in '67. And then there was this massive celebration that followed, you know, the legalization of homosexuality. And of course, you know, one of the great, you know, fun parts of the celebration was sex. And a lot of people were having sex with a lot of other people. And in the middle of this, you know, this huge celebration, this absolutely ghastly thing started to happen. It did start very, very small, inevitably. And I guess most people just ignored it. You know, most people didn't want to have their fabulous, young, dancey, great, wonderful, sexy lives disrupted by this horrible thing that was happening. So, you know, I would say in the very early stages, people kind of ignored it. And, you know, there were such tiny pockets of people who were becoming infected. But it wasn't before long, before the tiny pockets of people who were becoming infected became increasingly larger and larger pockets of people. And, you know, all of us started to know other people, you know, started to know people who were dying. And, you know, we also started to know people who, when it came, say, into the middle 80s, who had not just lost a few people, but, you know, people particularly in the two big American cities of New York and San Francisco, LA, who had lost as many as like 80% of all their friends. I mean, it was like, you know, the most hideous war zone, and people were dying in the most terrible circumstances, particularly because, you know, the administration at the time, led by Reagan, absolutely ignored what was going on. I mean, you know, there was a recorded conversation that was conducted in the White House in about '84, something around about that, where, you know, there was some kind of senator or some person who was trying to raise the subject of AIDS. And Reagan and his lot basically said, I mean, they basically said, who cares about the facts? Let them die. It was really, really extreme denial of what was going on. And, Reagan came into power in 81. He didn't even mention the word AIDS until 85. He did nothing about funding it until 87, by which time 1.5 Americans, mostly gay men, but also IDU people, sex workers, the at-risk groups, were positive, and about 250,000 people had died before the American government even started to do anything about it, even mention it. I mean, compare that to COVID, it's unbelievable, And also, with the whole safe sex things, it was illegal for condom makers to advertise that condoms could prevent, the spread of AIDS. I mean, in the mid-80s in America, it's just unbelievable. Fortunately, that changed. And, I have to say that queer people through organizations like ACT UP, etc., who became unbelievably militant and angry and effective in lobbying, for governments to pay attention, finance, changing medical, how trials were conducted, speeding the arrival of effective medication. Queer people really did something very, very important during that period of time, which in effect have saved millions of lives around the world.
Arguably, they're now the community that are the most aware and actually the most vigilant around some of the public health elements of HIV/AIDS, which just lends itself to Dr. Eric's point about education. So I suppose one of the key things about education is as Dr. Eric mentioned, around how actually it's groups that you wouldn't necessarily expect that now see the biggest spikes in HIV/AIDS. For example, adolescent girls and young women in sub-Saharan Africa are twice as likely to be infected than boys and men. Emma, in terms of how does that impact the communities that kind of do have that as their part of their daily lives, I suppose, now?
Thanks for the question. And I think, as we think over the last 40 years, it has become absolutely clear that HIV is sexist, it's racist, and it's classist. And it is now, as you've said, most likely to affect women, countries which are predominantly Black, and the economically disadvantaged. And when we think about the face of HIV now, we should be thinking of that of an adolescent girl. And, Eric has given us such a good kind of grounding in the statistics, but amongst those big numbers, 4,200 adolescent girls and young women are being infected every week. And the vast majority of them are in sub-Saharan Africa. 63% of the new infections in sub-Saharan Africa are women and young girls. And I think, that is the reality of our environment. 35% of those women have experienced intimate partner violence, and those who have 1.5 times likely chance of acquiring HIV than women who haven't experienced intimate partner violence, which doesn't mean that we shouldn't be working with lots of the other key populations. And indeed, Mothers to Mothers recently has started working with men who have sex with men, as well as with men and young boys generally. But I think it's absolutely invisible, I think, not to the people on this panel, but to the world at large, that women and girls are now being disproportionately affected, and that providing services and all of the education, training, support, stigma reduction that we have seen work so successfully with other groups over decades critically must be provided to women and girls now, as well as the boys that they are growing up with and the men that they are living with.
Have you told us, Emma, why women are becoming, why a far higher number of women are becoming infected? What's the reason for it?
Condom use. You know, women, you know, obviously there are, and I am not going to whatever the medical equivalent of mansplaining is. I'm not going to explain whilst we have an esteemed doctor with us, you know, the kind of the physiological likelihood of women and girls being infected. I will let Eric speak to that. But certainly what is absolutely clear from the women and girls that we're working is that they are not able to negotiate condom use. Yeah, a lot of them are having transactional sex. A lot of them are, as I mentioned, experiencing intimate partner violence. We are not able to have condom use where we would like it to be, and that's something we're really working on. Yeah. Clearly, you know, what has tremendously impacted this group are things like, you know, B+ when it came in, you know, women starting treatment for life rather than yo-yoing from, you know, treatment while they were pregnant, then coming off treatment. The fact that women are now largely, and particularly with the support of Mothers to Mothers community healthcare workers, being adherent to treatment throughout their reproductive years, when HIV positive is profoundly affecting the mother to child transmission rates. But until we can elevate the status of women and reduce stigma and discrimination around intimate partner violence and around condom use, then, you know, we're going to continue to see those infection levels.
Yeah, so empower women and educate men to behave more respectfully.
And, you know, and frankly, you know, there was a fascinating, PEPFAR did a really interesting study around the role of men in the reduction of adolescent female infections. And it, you know, their study showed that, you know, this wasn't about powerful men. This was kind of men who were experiencing all sorts of issues, who were feeling anything but powerful, and, you know, different things were at play in their sexual relationships. But absolutely educating boys and girls, you know, girls understanding consent, boys understanding consent. We're doing a lot of work with mothers and their daughters, and finding that mothers are finding out almost at the same time as their adolescent girls how critical bodily autonomy, consent is. And let's be clear, staying in school, you know, enabling women to make wider sexual reproductive health choices, working within the communities that we operate in, such that women have access to treatment, access to care. They're not necessarily having to ask mother-in-laws, other wives in polygamous relationships, if they can even attend clinics. So much of what we do is about creating that that bridge between communities and facilities, so that women and girls can access the knowledge that exists and the care that can be provided.
And the one piece that I'll add to that too is we need to make sure that everyone has appropriate access to medications, right? I think that you intimated this. Certainly not interested in mansplaining over here, because you did such a phenomenal job of this. But I think you are spot on. I think about this as 3 buckets. 1, power dynamics, right? 2 is education and addressing that education gap. And then the third thing is making sure that we have access to medications, because while we may are the things that we might be able to do to address some of the power dynamics that exist where HIV/AIDS transmissions continues, what I know is this: if the person who is transmitting to someone else were undetectable, they would be untransmittable, right? And so that's why I think we need to look at this as taking a multi-pronged approach. And a key element to that is making sure that every community across the globe has access to affordable medications, so that we can continue to use treatment as prevention and get as many people as possible with an undetectable viral load. That really is going to help us bend the curve here.
Yeah, and with respect, it's not just access to medication, but it's access to trained medical staff, because in a lot of countries, medication is now available. I mean, in Lesotho, which I know M2M have done a lot of work in, and we've done work in, they were very successful in 2006 or 7 at getting a sufficient supply of antiretrovirals, but they have like a handful of doctors and nurses. You need to have both. And, as MTM have been doing, they have also done in Lesotho, this expert patient. So they're enrolling HIV people. I know M2M have a big program doing that. And that's helped a lot, to actually bring treatment to people who otherwise couldn't get it.
And actually, Derek, it's far more than that. What we've done is we've really moved beyond that expert patient, paradigm, and actually trained and employed 11,500 women as community healthcare workers. We've called them mentor mothers, but we are, our organisation was founded by an Ob-Gynae working in Cape Town who realised that in the 7 minutes, if he was lucky, he had with each patient, he couldn't begin to relay the information and indeed, with the kind of huge kind of dignity of a doctor, realised that he wasn't the right person to affect behavioural change. Doctors do not affect behavioural change, peers do. And so in a kind of, in a sort of, killing multiple birds with one stone, what he realised was that in order to in any way eliminate paediatric AIDS and critically reduce maternal death, we needed to do health system strengthening, and we needed a whole new way of effecting behavioural change. And so what we have done, and what has been proven over and over again to be effective, is that task shifting, recognizing that in so many of our countries, so few doctors, so few nurses, and actually a cadre of professionalized peer workers supplementing the kind of huge demands in facilities, and actually doing that health system strengthening is the only way to begin to actually build up adherence and retention. Because I think, Eric, you're absolutely right, medication is critical, but I think certainly in sub-Saharan Africa there was somewhat of a build it and they will come mentality, and that wholly underestimated the stigma and discrimination that women were feeling and facing in any kind of access to healthcare. I've sat with women a 3-hour walk away from a facility in Malawi. They're not attending clinic because they don't have soap, and actually rolling it all back so that we understand whether it's, young boys living in Alabama or young girls living in rural Malawi, why is it that they are not accessing facility and services, and how can we create spaces that are as appropriate and sensitized to their needs as possible, and where necessary, how can we create a bridge from those communities to the health settings?
Yeah, well, you do amazing work. Congratulations. Brilliant.
I do absolutely none of it. The 11,500 women who...
You mean your organization, I mean, this Mentoring Mothers is clearly a brilliant program and works incredibly well.
But we need more of it. We know that there are 4.2 million healthcare workers missing in sub-Saharan Africa, and to affect the 2030 goals that we have as a global community, we are not going to hit those targets unless we dramatically increase the number of healthcare workers that there are on that continent and elsewhere.
I mean, this target is for 2030 is for an AIDS-free generation, isn't it? That's what the big aim is, isn't it? Which is a beautiful plan. I mean, of course, PrEP would be a wonderful way to have that sorted. If we could just ship out all the PrEP that we can well afford to produce and give away. this would be, I'm sure, this would be an amazing thing to be able to do. And I'm sure it's within the capability of the rich nations to do it. It's just having the will to do that, because, whatever the vagaries of stigma and education and, people are going to have unwise sex. We all have unwise sex, because we drink too much or take drugs or I don't know what we do. And, give people PrEP and they can basically do what the hell they like. And, Africans are no different from anyone else. We're all just people, for whom sex is a very important part of one's life, and it's going to happen, and irresponsible sex is going to happen. So let's just allow people to have irresponsible sex without it causing ghastly things such as, disease of whatever sort, and PrEP would sort that one. So
So in terms,
but I think we and I think I loved your slide on this, Eric. I don't think we can underestimate the impact of COVID in hitting global health targets, but certainly the 2030 targets. UNAIDS estimate that the clock could have and may have rolled back by 10 years. And I don't know what you're seeing in your practice, but we're certainly recognizing that if we weren't on track, we're really not on track now, and that whilst PrEP will be really, really important, each one of us will have a role to play, but until we address the social determinants of health and root out gender, race, income inequity, and that's not just on the African continent. I think of many
it's everywhere. It's everywhere in varying degrees.
Areas in some countries that should really know and think differently. Until we think about those determinants, we really won't go the whole way.
I completely agree with you, and I think that while COVID-19 has perhaps occupied the time and the resources and the efforts of organizations like the WHO and other people across the globe who are working to fight the spread of HIV and AIDS, I do think that, and you're 100% right about addressing the social determinants of health, because without addressing those disparities, we're never going to be able to move forward. But I do hope that what we've been able to do is in this, that we can leverage this as an opportunity. I think that there are a lot of lessons that we've learned in COVID-19 that maybe have offered us an opportunity to change the lens just a little bit about how we address global pandemics. I'm going to call it a pandemic because I think that that's the right word to use. But I think it will just give us a new opportunity to look at this disease with a fresh face, especially as we work into the recovery phase of COVID-19. So I hope that this will provide us some lessons and really renew some of the efforts that have been made to address HIV and AIDS over the last 40 years.
Fantastic. Thank you so much, everybody. It has been an absolute pleasure having you all join. I'm sure that hopefully everyone has a takeaway from this. There will be more resources on my social if you are willing to educate yourself. Give to the two charities that have been on today's call, AIDS ARC and Mothers to Mothers, and also any other resources that we think would help. So thank you everyone for joining. It has been an absolute pleasure, and I will be handing over to Senthil for closing remarks.
Thank you to today's expert panelists for enlightening us about the world's journey through the AIDS epidemic. I was young when AIDS was first identified 40 years ago. I was in my mid-teens when it started. I remember the striking news stories about otherwise healthy people falling ill and dying without clearly understanding what happened or how it can be cured. And then started learning more over the years as the medical community identified HIV and its causes. So on this 40th anniversary of the AIDS pandemic, it's important for all of us to continue learning and reflecting about the epidemic's impact over the last 4 decades. As Dr. Eiting noted, HIV has claimed an estimated 36.3 million lives globally and continues to be a major global public health issue. I was even more surprised to learn that some 38 million people are still living with HIV today, and 2/3 of them are located in the WHO African region. Those statistics dramatically highlight the disproportionate impact of HIV/AIDS on certain communities. Those who identify as LGBTQ, impoverished population in African and other developing countries, and children. HIV is still a very real and expanding epidemic. Governments, nonprofits, and the medical community must continue to focus resources and energy to managing its spread, providing care to those living with HIV, and advancing the science that can lead to a vaccine. Individually, we can help too. I ask you to find ways to be a source of understanding and support the HIV community. Continue educating yourself about HIV, learn more facts about the disease, and stay informed of the public and private initiatives to support progress in prevention, treatment, and research. Use that knowledge to prevent the spread of harmful misinformation. Help others in your circle of family, friends, and professional connections to understand the facts and reject the many myths about HIV. As you all know, there were a tremendous amount of myths about HIV. A lot of it has gone, but still there are some which are still circulating, and we need to figure out a way to eradicate them. Get involved in PRISM's work. Our own employee resource group is connected to organizations and institutions who would welcome your time and skills in support of their mission. All of us can be an incredibly important source of emotional support for those living with HIV. Empathy is a very powerful tool. We have learned through the COVID-19 pandemic and social unrest over more than 18 months that people want to be seen, heard, and understood for who they are and what they experience. As Derek Frost's powerful story illuminated, showing genuine empathy and compassion to those impacted by HIV is just as important as providing the most advanced medical therapies. Human spirit also needs care. Another point I would like to talk about is the stigma that is associated with HIV. I come from India where there was a significant amount of stigma attached to HIV, and the whole families were rejected and segregated. Uh, we need to help them get out of this. There needs to be much more care being given to them. We need to show empathy, not just to the person, but to the whole family. Finally, I draw a connection back to BNY Mellon's values and behaviors. We believe in strength and diversity, seeking out who is missing and helping everyone feel included. Together, we can ensure that those impacted by HIV feel that their differences, unique perspectives, and experiences are also valued and that they are welcome to participate to the fullest in the work we do. Following the example of the global COVID-19 pandemic, which united us in protecting ourselves, our loved ones, and others, let us come together again around HIV and AIDS. Educate yourself and join Hanaka, our PRISM colleagues, and each other in being active allies. Thank you.